I'm a plastic surgeon. I'm doing a lot of reconstructions, and I've been I have the privilege, have the experience using DermaClose for at least about a couple of years. In the beginning, I use it for the donor site, where we use for the free flap donor site closures. But recently, our group where we work do a lot of not only for the donor flap closures, but also routine wounds. There are also acute and chronic wounds. As we know, chronic wounds sometimes a little bit more challenging because there are a little bit more fibrosis involved with it. But certainly, depending on the type of the wound, the size of the wounds, as well as the tissue mobility, that is the most important part. Recognizing what is the tissue pliability, mobility, and what can be utilized along with the DermaClose will help in closing the wound a much better rate than using conventional modality in wound care techniques. So, for example, in comparing the utilization of DermaClose by itself versus the skin graft, the one that we know for sure is one patient who has a wound created for fasciotomies. And in the past, people use skin graft as a primary modality in trying to get the wound closed. But I think when you use DermaClose immediately and appropriately, you can actually avoid skin grafting the patients. By avoiding skin graft, actually you might have a better cosmesis results rather than having a divot from the skin graft on the wound itself, versus a primary closure, or what we call it secondary closures, that is assisted with the DermaClose. I think they will provide you with a much better result.